following episode is brought to you by the American Urological Association. This episode is part of a special series highlighting the AUA Update Series Volume 45. In this episode, we will be covering some of the key lesson points with Dr. Mantu Gupta, one of the authors of Lesson 17, Kidney Stones and the Infected Patient. Now in its 45th installment, the AUA Update Series is renowned for delivering high-quality lessons to practicing urologists, fellows, and residents. All content is developed by internationally recognized experts in urology, making the AUA Update Series the most professional and sought-after self-study program available. Improve your practice and patient care by staying abreast of the latest treatments and surgical techniques in urology. For more information or to subscribe to the AUA Update Series, please visit the AUA University.
Welcome to another episode of the AUA University podcast. I'm Dr. Mark Gonzalgo, professor of urology at the University of Miami and chair of the AUA Office of Education. Today's episode is part of our AUA Update Series and focuses on an area of stone disease that remains both clinically challenging and critically important: kidney stones in the infected patient. I'm pleased to welcome Dr. Mantu Gupta, professor of urology at the Icahn School of Medicine at Mount Sinai and director of the Mount Sinai Kidney Stone Center. Dr. Gupta is a recognized expert in endourology and has made major contributions to the understanding and management of complex urinary stone disease. Mantu, welcome. It's wonderful to have you with us today.
Thank you, Dr. Gonzalgo, and I welcome the AUA audience to this important podcast.
Before diving into specifics, let's start with the big picture. What makes the infected stones such an important topic for the update series, and why should practicing urologists pay particular attention to this lesson?
Well, I think one of the most devastating complications we face as urologists is urosepsis. And one of the most common causes of urosepsis is the infected kidney stone, whether it's a patient who comes into the emergency room with an infection that is already there, or it's an infection that is spread from the urinary system to the bloodstream by an intervention that we perform, whether it be ureteroscopy or just a stent placement or a percutaneous nephrolithotomy.
That's great. And you know, I think that when you're talking about the topic of infection stones, and obviously you mentioned serious conditions such as sepsis, why do you think infection stones are often underestimated clinically?
Well, I think sometimes it's very difficult these days in particular to know whether a stone is infected or not. Many patients are already on antibiotics and masking the infection, and many stones look like typical metabolic stones and are actually staghorn infected stones. In addition, many of our infected stones these days are not the classic struvite stones that we're used to reading about in the literature and seeing over the years, but many metabolic stones, by metabolic I mean calcium oxalate, uric acid, or a mixture of them, including calcium phosphate. Typically non-infected stones these days often have bacterial biofilms on them that can make them infected, or even have some bacteria within them that make them infected. And so those are risk factors that we don't always appreciate when a patient presents with a kidney stone.
One thing this lesson emphasizes, I think, very effectively is that infected stones are not simply stones with infection. They represent a distinct disease process, as you mentioned, with unique microbiology and, of course, recurrence behavior. And another practical part of this lesson, I think, are the visuals, including a table that's included. We'll refer, for the purpose of the podcast, to Table 1, which really helps organize the spectrum of infection-associated stones. So, Mantu, can you walk us through the key teaching points from Table 1 and how clinicians should think about these different stone phenotypes?
Yeah, so it's not just one type of stone that can be infected. Like I was mentioning earlier, a typical classic struvite stone is what we think of as an infection stone. And these are stones that are triple phosphate stones or made of magnesium ammonium phosphate caused by urease-producing organisms. These are organisms that break down urea that's in the urine and gives urine its yellow color into ammonia, which then becomes incorporated into the stone. So these stones grow rapidly and are difficult to eradicate, but these are not the only phenotype of stone that can be associated with infection. Carbonate apatite stones, which look like a typical kidney stone on an X-ray or CT scan, hard to distinguish because they're just as dense as a regular kidney stone, compared to struvite, which tends to be less dense, and we know that they are less dense, so we often can pick them up on an X-ray, for example, are also infection stones, and they are just as bad as struvite stones in terms of having a risk for urosepsis. And then it could be a regular kidney stone, a mixed calcium oxalate or apatite stone that became secondarily infected. It's a kidney stone that bacteria became associated with the stone later on. And it could be a biofilm around the stone, or it could be bacteria inside the stone, as newer studies have shown. And then finally, something very underappreciated are fungal stones, stones that are associated with Candida species or other species. And candidal sepsis is one of the worst types of sepsis that can happen. So it's very important to recognize when a stone may be infected with fungal material. This is often doesn't show up on a bacterial culture. And so it can be a high index of suspicion is very important for this type of stone.
As you mentioned, it's important to understand that the nature of the stones can be rather complex. One question I think that some of us in the audience, including myself, ask are, how reliable are urine cultures in these patients? And, even going beyond one step, how do stone cultures change management meaningfully, if at all?
Yeah, a very good question, Dr. Gonzalgo. And this is a very important point. And a lot of our research goes into urine cultures and how we can detect bacteria. So a preoperative urine culture, of course, is mandatory whenever you're doing a PCNL. That's part of the AUA guidelines. But interpreting that culture is also equally important. If someone is already on antibiotic and you do a urine culture, that urine culture will be negative. That doesn't mean the patient doesn't have an ongoing infection. And if the antibiotic is completed its course before you actually do your procedure and there's a gap, the bacteria could still be in there and you can get sepsis even though you had the patient on the appropriate antibiotic for the UTI they had. So a negative urine culture in a patient who's already on antibiotic doesn't mean that it's patient's not infected at the time you do the surgery, unless the antibiotics continued until the surgery. Number two is that often a urine culture will show mixed growth, and a urologist or other practitioner will interpret that as being a negative culture. And that's not necessarily true. A patient can be infected with multiple organisms, or if there's multiple organisms, it could be masking the true one bacteria that's in the urine that's causing the stone. So what we often do is have those patients with multiple organisms come in for a catheterized urine sample, getting a sample directly from the bladder. So that if there's any contamination that happened to the previous sample, we'll be able to avoid such contamination with the catheterized sample and get a true assessment for what's inside the urine. So I encourage anyone who's treating any type of suspected infected stone or staghorn stone to get very clean midstream samples. And if it looks like it may be contaminated or multiple organisms, to actually do a cath sample. You did mention stone culture, so I should talk about that as well.
Sure.
We are doing stone cultures in virtually every patient, but much of that is for research purposes when we do a PCNL. But any patient that you suspect of having an infected stone or had a previous urine culture that was positive prior to the stone treatment should have the stone actually sent for stone culture. And how that's done is very important. The stone should be gathered in a sterile cup. It should be crushed with a mortar or pestle or other crushing device in a few drops of saline to create a slurry. And that slurry is what should be sent to the microbiology lab to get plated. That's very important. These days, we're also sometimes doing DNA testing on the urine prior to surgery or of the stone itself. And that's a research project we're doing now to see if DNA testing can detect bacteria that aren't typically detected by standard bacterial stone cultures or urine cultures.
Well, thank you. Very practical knowledge, as I was mentioning earlier. And I think it also highlights the fact that, residual infected fragments can sometimes be fundamentally different from residual metabolic stone fragments, since they often behave as a persistent infectious nidus. So, those additional ways to culture stones may be very useful in certain patients. Another area the lesson addresses very practically is postoperative suppressive antibiotic therapy, which is actually summarized nicely in a table in the lesson, table 2. Mantu, how do you approach suppressive antibiotics after surgical management of infected stones?
Yeah, so our approach is very practical, and it's based on previous studies that have been published and are including our own work. The first thing I think is very important is to distinguish whether this was a primary infection stone or was it a secondarily infected stone. And that's an important distinction. So a primarily infection stone is a struvite or carbonate apatite stone. That's a stone that's typically produced by urea splitting organisms, and the infection was the cause of the stone. It's the chicken or the egg problem. What came first, the infection or the stone? So if it's an infection stone, a struvite or carbonate apatite, that means the bacterial infection came first and produced the stone. Those are the patients that need long-term suppressive antibiotics. If it was a metabolic stone, like, for example, a calcium oxalate monohydrate or dihydrate stone that was associated with infection, in other words, bacteria were found in the urine at some point prior to the surgery or during the surgery in a stone culture, that stone is a primary metabolic stone that became secondarily infected. Those patients do not need suppressive long-term antibiotics. The focus in those patients should be on stone prevention, because if you prevent the stone, chances are you're likely to prevent an infection as well. Whereas with the infection stone, the infection causes stone. So there you need suppressive antibiotics. And we have a list in table 2 of the common antibiotics to use. One mistake a lot of practitioners use is using a regular dose of antibiotics for prophylaxis. You have to remember that bacterial resistance occurs with higher doses, but with smaller doses, 1/8 the typical daily dose is what we use for prophylaxis. That's 1 time a day, 1/8 of the standard total daily dose. So for nitrofurantoin, for example, we typically use 50 milligrams daily. Or for Bactrim, it would be a single strength tablet once a day. For cephalexin, 250 milligrams just once a day, and amoxicillin's 250 milligrams once a day, as it shows in the table. A low dose suppression is less likely to cause antibiotic resistance and other side effects. So the goal of therapy there is not to cure, it's to keep the urine sterile and prevent bacterial superinfection.
This is an area where real-world practice often varies considerably, and I think listeners will appreciate the practical framework that the lesson provides with respect to this area of stone disease management. One of my favorite educational components of this lesson is actually Figure 1, which visually maps the disease course of infection-based stones. Mantu, what do you think Figure 1 helps clinicians conceptualize most effectively?
Well, I think it gives some framework on how these stones form and how the patient progresses, because most of these steps in this figure occur well before we ever see the patient. We see the patient once they've already have recurrent UTIs, or once the staghorn stone or infection stone has been diagnosed on an ultrasound, X-ray, or CT scan. But a lot was happening before we ever saw that patient, and it's important to understand those steps. So the primary step was an infection with a urease-producing bacteria that colonized the upper tract. Most of these infections actually, and even the stones themselves actually, are asymptomatic, meaning the patient had no idea they had a urinary tract infection, no idea often that they have a staghorn stone in their urinary system. And because these stones can be asymptomatic and the bacterial colonization of these stones can be asymptomatic, often they don't get picked up until a late stage when this complete staghorn is formed. So the first step is bacterial colonization of the urinary tract. Then the urease activity increases urine pH and produces ammonia, as I mentioned before. And then the ammonia combines with magnesium and phosphorus to form the classic struvite magnesium ammonium phosphate stone. But often carbonate apatite, which is another stone composition type that's produced by the same bacteria, can often be mixed with struvite components. And many stones have both struvite and carbonate apatite components. And this all occurs before we ever even see the patient.
The figure really reinforces, I think, what successful management is like, and that it's not simply operative. You mentioned a lot of this happens before you even see the patient. Certainly, it can last even after surgical treatment of the disease. It's really longitudinal disease control that's very important. We talked about this earlier before we came on the podcast, that something about this lesson which is unique is that it includes an operative video on staghorn stone management, and one that I've watched and appreciated since I typically don't do this type of surgery, but recall my days as a resident doing this. I think many learners are going to gravitate toward this immediately because it's very helpful and very clear in terms of managing a staghorn calculus. What are the key technical and philosophical lessons you hope learners would take away from the surgical video that's in this lesson?
Yeah, so treating a staghorn stone typically with PCNL is different than treating a normal kidney stone. One technique has to be meticulous in order to minimize the chance of complications. So you need excellent drainage of the urinary system to not create high pressures and risk sepsis. Number two, the access has to be very precise and has to go into the location that's going to allow you to get the most stone burden with a single access that's possible. And as you mentioned earlier, that residual fragments, especially in these cases, can lead to recurrent infections and stone growth. So it's important to get every fragment out. In order to do that, you need to have the perfect access. So a access into the urinary system that allow you to get to the most stone burden, and that's typically an upper pole or lower pole access in most situations, is important. Planning it pre-surgically with the CAT scan is important. Because these stones are filling the collecting system, often there's no space around the stone in order to do the access. So typical fluoro-guided or ultrasound-guided access will often fail because the needle will hit the stone, but there's actually no space for the guide wire to go, and this guide wire will bounce out of the collecting system and into the renal tissues or extra-renal tissues. And so when you do your tract dilation, you think you're going into the collecting system, you're actually not. So endoscopic guided access can help in this situation, but also certain techniques of making sure the needle's buried inside the stone, being careful with your advancement of your nephroscope through the sheath to make sure you're in the collecting system. And if you're short of the collecting system, it's not a time to panic. Often your needle did hit the stone. It just was not enough space there for the guide wire to go. So following the tract carefully, you can find the stone. And then finally, using a combination of flexible ureteroscopy, nephroscopy, and standard rigid nephroscopy is important. A combination of all these different techniques will be important to get every fragment out.
No, I think the video, I think, speaks for itself and really is a technically great visual on how to treat a staghorn, and also perhaps highlights, based on what you've just said, that judgment during these procedures probably is equally important, if not more important, some would say, than the technical skill itself. As we wrap up, what would you say to listeners about why this particular lesson is worth their time?
Well, again, as I mentioned at the beginning, sepsis is one of the most feared complications we have in urological surgery. And when you're dealing with an infection stone or an infected stone, the risk is extremely high. So maintaining low intrarenal pressure and following the steps we've talked about in this update series, extremely important for minimizing the risk of sepsis and preventing long-term injury to these patients. Many of them end up in the ICU. So this is a very important lesson for all practitioners.
Mantu, thank you for an outstanding discussion. This lesson does a tremendous job distilling a highly complex topic into practical, clinically actionable teaching points, and your insights really help bring the material to life. I think one of the major takeaways for our listeners is that infection-associated stones represent an entirely different level of disease biology and surgical complexity, from microbiology and biofilm formation to operative planning and long-term recurrence prevention. These patients require thoughtful and comprehensive management. The tables, visual framework, and the surgical video in this update series lesson are exceptionally valuable educational tools, and I strongly encourage our audience to spend time working through the full content. To our listeners, thank you for joining us today. For more educational content, including AUA Update Series lessons, podcasts, surgical videos, and CME resources, please visit auanet.org/university. I'm Dr. Mark Gonzalgo, and we look forward to bringing you more conversations that advance excellence in urologic care and lifelong learning. Until next time.